Thank you. All right, over to you, Scott.
Okay. My name is Scott Abbott, and I am the Mental Health Services Act Program Manager for Lake County Behavioral Health Services. And I want to welcome everyone to our public hearing. And I've asked Julie Colfax, who's our Mental Health Advisory Board Chair, to say a few words. She's actually, the board is actually hosting this meeting. So Julie.
Thank you very much. Yes, Julie Colfax Pennington. I have two last names now. Obviously, I need to change my little name on the Zoom screen.
I guess that's congratulations too, then, right?
Thank you. It was last year, but I'm still working on the name change. I am the chair of our Lake County Mental Health Advisory Board, and our responsibilities include hosting this public hearing each year for the annual update and on the 3-year mark for the 3-year MHSA plan. And so that's what we've got going on this year. And so I am happy to be here and see everybody's wonderful faces. I am a licensed marriage and family therapist working here in Lake County, and enjoy functioning on the board to help support our behavioral health services and our board of supervisors. I know we have a few other board members here as well. And so one of our primary purposes, in addition to hosting this plan, is to ensure stakeholder involvement in this process and in all of the services provided by behavioral health services, both the mental health services and the substance abuse treatment. And so that is our role and why we are responsible for hosting this event, although most of the coordination, thank you so much, is done by RDA Consulting and our Mr. Scott Abbott. So on that note, I will hand it over to, is it Aditi?
Yes, that's right, Julie. Thank you.
Thank you so much, everyone, for participating. Your voice is so valuable, and your input and your involvement. And we just want as many people here to help share ideas and advice, anything we can do, even the voice about what we need more services on. So thank you very much, everybody. All yours, Aditi.
Great. Thank you so much, Julie.
Thanks, Julie.
Great. So this is the official welcome and kickoff. So again, thank you so much, Julie, for that introduction. As Julie mentioned, my name is Aditi Das, and I am from RDA Consulting. I have two other colleagues on the call here today, Paulina Hatfield and Jamie Dorsey. And as Julie mentioned, we've been working very closely with Scott's team on the LCBHS MHSA 3-year reporting process. And so we're very excited to be here today to present a lot of what we've learned, honestly, from your very, very valuable inputs. And that's really what we're going to be talking about today at the public hearing. And so just as a quick way of, orienting folks to who all are present here today, I just want to again warmly welcome everybody. This is the public hearing that we're hosting now. And this is, this for some folks, we reconvened at the second community meeting that we RDA and LCBHS hosted back in March. So we've taken a couple of learnings from that. One of the things we've tried to do is make some of the materials available to folks in advance. So really hope that, the slide deck that I'm presenting here today, folks have had a chance to look at that ahead of the meeting. We will be moving through that slide deck. So hopefully that kind of helps as you as we walk over this process. The other thing I wanted to mention is that the slides have been made available and posted online on the LCBHS website. So if you'd like to follow along, definitely look at that. We also really want to deeply acknowledge and thank folks who have come here today, who've made time to be here at this meeting. We understand that the hybrid meeting format can always get a little clunky, but we really appreciate folks who are here. We have been very grateful to receive all of your valuable inputs and feedback throughout the 3-year planning process, and want to continue to encourage your active participation here today. We have multiple stakeholders present. I just want to give a shout out to a few so that folks get a sense for who's in the room. We have our facilitators from the various peer support centers today, such as folks from the Circle of Native Minds, Big Oak, Lavos and Harbor. So really big thank you to all the Peer Support Center facilitators, as well as the consumers and providers who are joining us here today. If I could get the Peer Support Centers to give us a sense for how many folks they have in the room so that we can get an idea of their participation, that'd be great. You can either get off mode or maybe chime in via chat. That would be really helpful. And so I want to just give it maybe a minute or two in case anybody wants to come off mute. And okay, like I said, feel free to chime in via chat. Would love to learn more about the folks who are at the peer support centers. In addition, we also have several program and agency partners who are here, along with some key LCBHS agency staff. We really, again, want to reiterate how much we're grateful for all of the time you've taken to participate in a number of sessions we've hosted really through this year, already starting January until now. It's been really important information that we have really collated, and that's one of the things we're going to be talking about today. Unfortunately, in the interest of time, we will not have the opportunity to kind of do a round robin introduction. So if folks can just chime in via chat, that would be wonderful. And you see that up here on the screen, if you want to kind of put in your name, your pronoun, as well as the program that you represent, or any kind of affiliation that you have with LCBHS, that would be really beneficial. So again, thank you so much for being here, and I'm going to move us along. All right, great. I see a lot of activity in the chat. Thank you. All right, so let me get into the agenda, really why we're here today. So one of the key pieces of today, the public hearing, is we're going to kick it off by giving folks an overview of what MHSA is, and then we're going to provide that background, as well as give folks an understanding of what that 3-year planning process has entailed, especially with the kind of community stakeholder engagement that we've been working with. And then we will be presenting the community needs assessment findings. And like I said, that's been an effort that we've been involved in since earlier this year. So we'll be kind of giving you a high-level overview of the community needs assessment findings. And then coming out from the findings, we did also talk about some potential program modifications that have been proposed for FY 23 to 26. We will then talk about the program budget requests and the way that allocation is going to happen, especially as we move into the next couple of years. And then we will open it up for public comment and discussion, which is really going to be the bulk of today's conversation. So would really want to, again, reiterate that we'd love to hear from folks, especially when we reach that part of the section. Meanwhile, as always, feel free to continue to chime in via chat. We will be monitoring the chat space. Outside of the agenda, I wanted to also kind of raise the 2 key objectives of today's meeting. The first one is that we will be presenting this proposed MHSA 3-year plan, and this has very much been developed with the community input. And we will provide an opportunity for stakeholders to provide public comment. That's really one of the big pieces of why we're here today. Couple of meeting tips for folks. Sure folks are fairly familiar with this, and I just want to make sure we go over these. For those of you who are in attendance today, especially those who are here in person, it would be great. We have our facilitators and coordinators there on site to help manage the Zoom meeting. Again, thank you so much for that, and help facilitate some of that attendee participation. If you're joining us virtually, try, if you can, to find a quiet, distraction-free location. And then consider closing any other applications to improve your Zoom performance. If there are any substantive comments or feedback that folks would like, or any kind of clarifications or questions, feel free to either use the raise hand function on Zoom or enter your question in the chat. As I mentioned, we will be monitoring the chat very closely. And it's also true for those who are attending in person, especially those at the peer support centers. Ways to contribute to today's discussion. If you're joining us via the computer, definitely speak through your computer, click on the participants icon. If you kind of hover at the bottom of the screen, you'll see the raise hand function. So definitely use that. We will we will definitely get to your question. If you are calling in via phone, press the *9 symbol, because that it tells us that you have a question or clarification that you'd like to pose. Please use the Zoom interface via chat to add any thoughts. And then we also have Scott's email address up here, so feel free to email Scott with any thoughts or feedback. Great. On that note, I'm actually going to officially kick us off, and starting off with the first section, which is the Mental Health Services Act training and education piece. Just want to reiterate, this might feel familiar to a lot of folks, but we will want to make sure that everyone on the call is aware of what this entails. So a little bit of a background about the Mental Health Services Act. This was a act that was passed due to Proposition 63 back in November 2004. It's a 1% tax on income of over $1 million. And the intention of this is really to help expand and transform public mental health services. And there are 5 core values or guiding principles that are a part of the MHSA process. And you can kind of see these buckets up here on the screen. They include wellness, recovery, and resilience, a focus on cultural competence in terms of the delivery of services within LCBHS, MHSA, ensuring that the client and the family are really at the heart and the core of all services and are very much driving their care, ensuring that the service experience is integrated, as well as really focusing on making sure this entire process is a collaborative engagement with the community. So that's really some of that background detail of what MHSA is. When you kind of think about the funding for MHSA, and really this is, again, some of the key buckets of how the funding is distributed within MHSA. A large majority of that goes to CSS, which stands for Community Services and Support. This is really focused on the kind of outreach and direct services that are provided to clients and really across the age spectrum. And then within that, half of the CSS funding tends to go to full service partnerships. That's a part of the way MHSA, the allocation happens. Then when you look at the next bucket, it stands for PEI, which means prevention and early intervention. This is really focused on preventing the development of mental health problems, and kind of it's focused on screening and early intervention, especially when you see early signs. About a half of PEI funding tends to go to children and youth services that are wide ranging for early intervention and providing inherent program flexibility. We have the Innovation Fund, which is about 5% of the budget, which is about testing out novel new approaches that can help improve outcomes. We have the WET, which stands for Workforce Education and Training, as well as CFTN, which are the Capital Facilities and Technology Needs, which is really sort of focused on the resource infrastructure that is really how LCBHS, MHSA services are delivered. I'm not gonna read all these details here, but what you see up here on the screen is just based on the buckets that I just discussed. We have the list of all LCBHS current MHSA programs under these different brackets, so that folks can get some familiarity of the range of programs that we had. And again, quick note, we had our first community meeting. This was back in early February, where we had the programs actually report out on each of on really what they've been up to this past year. And those details are already up on the LCBHS website. So definitely take a look at that if folks are interested. So we have all of that information up there. So just want to, again, just give it a couple of seconds before I move on so that folks can get a sense for the kind of MHSA programs there are. All right, great. Thank you. To learn more about MHSA programs, again, this is a plug for the LCBHS MHSA website. I'm going to have my colleague drop the link in the chat so you can access it and know where a lot of these materials that I just talked about are available. Moving into section 2 of this public hearing discussion, this is where we're going to talk about the 3-year plan as well as what that community planning process has looked like. So one of the big intent and purpose of the 3-year plan is to identify persistent mental health service gaps as well as develop strategies to try and address them over the next 3-year fiscal cycle. And a lot of this, the basis of this has been the community needs assessment as well as stakeholder input. Specifically, we've received input on the program status and service accomplishments for financial year 21-22. We're looking at a proposed program plan for the next 3 years, which is the FY 2023 to 26 cycle, as well as programs that are actually changing this next year, starting 23-24. So those are some specifics of what we focused on. And the community planning process, one of the core tenets of MHSA is to really engage and have a meaningful engagement with stakeholders, because we really turn to stakeholders as the subject matter experts in the development of these plans, which is very much focused on utilizing the MHSA funds at the local level. So that's really what a lot of the community planning process has looked like. Quick overview about the prevention and early intervention evaluation reporting. Back in FY 18-19, the MHSOAC updated the PEI reporting requirements to include some evaluation of PEI programs. These included 2 things, which was the PEI annual report as well as the PEI 3-year evaluation report. They sort of covered very similar areas, which is, kind of understanding the gamut of consumer served, consumer demographic information, program accomplishments. The only difference was with the annual report, it was based on the previous fiscal year, whereas with the 3-year report, it was based on the previous 3 fiscal years. And then, of course, the focus was also on specific implementation and outcome information. And so one of the things we recently did in this last year is that we've been working very closely with programs to strengthen some of their data collection and outcome reporting measures, and really to strengthen overall PEI specific reporting. So that's some of the tenets of the PEI evaluation process. Wanted to give folks an overview of really the range of MHSA stakeholders that LCBHS works with. So you can kind of see this list it goes down from consumers down to providers. So really anyone who touches the mental health system within MHSA. And so I just wanted to show folks an idea of who the stakeholders are. And then just wanted to also highlight some key roles and responsibilities, starting off with the stakeholders. We've really leaned on the stakeholders to learn from their lived experiences and share reflections of emerging strategies to meet some of the community needs. We have the Behavioral Health Services Department, where we've developed the MHSA 3-year plan that's reflective of the community needs, priorities, and strategies. We have the Mental Health Advisory Board. Julie kicked us off today, and we have some other members of the board who are really focused on, reviewing and advising the MHSA 3-year plan, and are conducting today's public hearing. We have the Board of Supervisors who review and approve the final MHSA 3-year plan. And then we have us, that's RDA. We have been working very closely with the LCBHS team, Scott and some of his team members, to really kind of help facilitate and collate a lot of this information that we've brought today. And again, just to give an idea, folks, an idea of the timeline of the various planning activities that went behind this MHSA 3-year plan process, where we have 4 key phases, and we're currently now in the 4th phase of the plan development. As you can all see, we posted this plan last month, and then we are here today at the public hearing. Right after this, we will be finalizing the 3-year plan, and there's going to be an official presentation to the Board of Supervisors. So just kind of give you a sense for all of the different activities that we've been working on through the different phases of this program, of this project. All right, so this is where, and again, I apologize if that was a little speedy, but we definitely have a lot to cover today. So as a part of the MHSA training and education piece, we wanted to quickly launch a stakeholder poll. I'm going to put it up on the screen and have folks respond to it. And we can definitely have folks even from the peer support centers respond to this. So I'm going to go ahead and launch it, and we'll open it for a couple of minutes. So you can see there's a question up here on the screen, which is just, we'd love to get an idea of how much folks have whether they have a relatively good understanding of what MHSA is and the Lake County's 3-year plan and the community planning process for FY 23 to 26. So thank you so much for taking the poll. Go ahead. Do we have some more?
Yeah, I was just gonna add, the reason we do this poll is it provides evidence that people feel like that they did receive some training. That was one of the things that the state asked that we ensure that we do. So thanks for participating in this.
Thanks, Scott. Thanks for that context. Okay, thank you. I'm going to keep it open for just maybe 20 more seconds. Great, thank you. Thank you. The response from, I see the response from Harbor. Right. Thank you all for joining. I'm just going to end the poll and quickly share the results. So it looks like we have a large majority who strongly agree. And then we have about 31% who agree and about 15% who feel like it's neutral. So that's great. Thank you so much. And I just want to reiterate that a lot of this information is available on the LCBHS website, so you can learn more. There's always a lot of resources and information about MHSA and the community planning process. Thanks again. I'm going to now move us along to section 3, which is the community needs report back. And, do bear with me. There's just a lot of information coming your way. Hopefully folks have had a chance to look at this and know that, this is something we also presented at the second community meeting. Okay, so let's start off with giving folks an idea of really who participated in the needs assessment process. So right here, the table on the left, you can see it kind of constitutes the kind of activities that we undertook. So started off with the community survey that we launched in January. We had 108 participants to that community survey, which has been great, and we really appreciate that response rate. In addition, we hosted 2 community meetings. This was both in February as well as March, where we had a total of 155 respondents. And then we also, in between the 2 community meetings, had launched some focus groups. This with both providers as well as consumers. And then we also hosted a community listening session. So the total participants for the focus groups were 43. So that brings our total number of participants to 306, really starting, as I mentioned, earlier this year in January. And then when you look at this bar chart on the right hand of the screen, this will give you a sense of the stakeholder affiliation for our community planning process participants. So you could see that, we have about 28% of those folks were those who identified as the behavioral health service providers. 17% are those who identify as consumers. And then we had about 27% who identify as other community stakeholders. Again, this has been a really terrific participation, and we want to send out a huge shout out and are very grateful for folks' inputs. This is now kind of getting into the findings piece. What I'm going to start off with is giving folks a sense for really what were some of the findings that we can glean from the community survey. As I mentioned, there were 108 individuals who participated in the community survey. And just know that, those who participated, not everyone completed the survey. So there are some questions that weren't answered. And just to orient folks, the community survey included about 13 Likert scale questions, where basically participants were asked to rate how true various statements were regarding participants' experiences with the MHSA services provided in Lake County. And the range of the Likert scale was from very true to do not know or not applicable. In addition, we also had 5 open-ended questions, and we analyzed that as a part of the qualitative data, which comprise some of the key themes, which we're going to show you next in the slide. So what I'm going to do is just give everyone an understanding of just what are some big key takeaways from the survey findings. So overall, there are several elements that had strengths and challenges, where we see about half of the individuals, they find an aspect of the LCBHS to be very or mostly true, and about half find an aspect of services to be a little bit true or not. This also shows up in many ways in our qualitative data findings, and we're going to be discussing that in the next section. Overarchingly, we see that there's a theme wherein most survey participants generally do not feel that existing services are sufficient to meet the community's needs and can be difficult to access. However, the big takeaway is that once you get into the services that LCBHS MHSA has to offer, that the service experience has generally been positive. So again, in the interest of time, I unfortunately can't go over each of these pieces, but I wanted to give folks a sort of overarching sense of what we've been learning from the survey results. So starting off with some of the needs assessment system strengths, we want to start off with giving everyone an idea of what what folks and the stakeholders called out as strengths of the program. Peer support centers was a big piece where, folks talked about how the convenience of their location, the fact that peer support center staff are really helpful and welcoming was something that was called out. The extended hours of operation for improved client access, and that, the idea that peer support centers serve all people regardless of their niche was really another piece that was raised around peer support centers. Outside of peer support centers, both LCBHS staff and leadership were stated as being very friendly and supportive. They're very caring and dedicated and being very client-centered. Service participation and collaboration was really focused. There was a lot of focus and emphasis on talking about the open communication and really the lack of preventing duplication of services, which can happen within such a large system. And then there was this other piece which talked about how services are accessible when the following conditions exist: when services are done in a responsive and timely manner, when transportation is available, and flexibility is afforded to the consumer. So there's sort of conditions which we heard from stakeholders around where services were working for them. Telehealth and virtual services were generally sort of seen in a positive light, which has increased service availability and accessibility for the consumers. And there was a special shout out made to some programs that we have listed here. Outside of the peer support centers, folks talked about how Motherwise, the FSP program, psychiatric services, and senior peer counseling were really well received by stakeholders. And you see up here in these little bubbles that we have here are just some of the quotes that we have from both the consumers as well as some participants at the community listening session. Talking about, one of the other pieces coming into the needs assessment process is really learning about some challenges and persistent needs. And these were the different pieces that were raised. The first one was where stakeholders talked about the staff shortage and issues on retention. Specifically, there was a conversation around limited access to trained and licensed clinicians, limited staff capacity, which tends to affect timeliness as well as the kind of quality of care. And it's also, in many ways, folks raised how it's hard to recruit providers due to pay, cost of living, location, etc. So those were some of the challenges that were raised around staff shortage and retention. In addition, stakeholders also highlighted barriers to accessing and participating services. This included service access challenges, things like transportation, the specific location of programs, Wi-Fi, broadband issues, program closures, and limited hours. There was conversation around insufficient culturally competent services. This is particularly thinking about the Latinx and the Native American communities. Timeliness of services, long wait times, and lack of responsiveness, as well as low levels of service awareness and knowledge was also something that was raised, especially by consumers. COVID-19 has continued to have an impact on services, and the pivot to virtual services, it has worked for some, but it hasn't worked for everyone. And so that's something that was again raised in our conversations with stakeholders, as well as service gaps and a lack of infrastructure support for care coordination. Again, want to highlight some of the key quotes that we had from our qualitative findings up here on the screen. In terms of Lake counties, those who are, we also asked folks who are populations that are in need, and there were, this is a list of those who were, called out. Specifically, they talked about the unhoused population, where there's a lack of awareness and really a lot of challenges in terms of following up with this population. There were, some challenges raised with co-occurring issues, especially amongst with substance use. There is, there's a need for more of an emphasis on school-age children as well as families and parents, especially with, with lowered mental health classroom engagement, and there's been a high suicide rate amongst youth. With youth and the day center specifically, there were, stakeholders raised transportation issues as being a barrier. With the LGBTQ plus population, there's a need for safe spaces to feel, for folks to feel accepted. The undocumented population was also raised as a population in need. We had the older adult population where access challenges continue to be persistent. The Latinx community, especially those who are non-English speaking, there is a lack of bilingual services and really a lot of historical lack of trust. With the Native American community, this is across all age groups. There has been a rise in teen suicide, elder abuse, and also there has been a historic lack of trust. With populations in rural areas, there continue to be some access challenges, and similarly, another population in need was the perinatal and postpartum mothers. So with some of the strengths, challenges, and populations in need, these are some of the proposed strategies that stakeholders came up with regards to addressing some of the system needs and gaps that exist. So I'm going to kind of walk over.
I tried to connect you.
Oh, sorry about that. Could I kindly request folks to put themselves on mute, please? Thank you. Great. So the first one right here, I'll go from sort of left to right, is starting off with service awareness, outreach, and access. One of the pieces that was identified was improving staffing, such as, introducing behavioral health system navigators and community health workers, address transportation barriers, increase outreach and awareness about LCBHS programs in general, provide more telehealth supports, as well as improve convenience of locations. For instance, launch satellite clinics, have more home visiting options, amongst others. With regards to service coordination, there was discussion around improving communication between different agencies and partners. There is this, the need was raised around adopting a database to track clients. This includes things like the ECM or the Pathways Hub, and really avoid silos and have greater alignment with other similar initiatives like CHIP, as well as Hope Rising, which I believe is already in the works. With regards to workforce education and training, some of the workforce incentives, there's an opportunity to think about what that might be, as well as really grow your own staff, which is there an opportunity for staff within LCBHS to kind of move up the ranks, and really how do you build that workforce from within? And then also there's a need to provide more culturally competent trainings. When you think about the need for consistent funding, this would be to sort of, to make for dependable programs like things like the warming shelters or after-hours services, improve technical assistance, organizational capacity, and expand building and facilities in general. Ensuring that there's consistent funding for that. there is a need for new services or expansion of existing services. This includes things like prevention services, mobile crisis response team, expanding the range of youth support services, provision of additional adult FSP programs, expansion of case management services, expanding co-occurring disorder services, as well as a growth of postpartum and perinatal services. And some other system needs that were identified include things like expanding SUD services, improving access to basic needs like shower services, comfort of homeless persons, etc., enhancing social community events, the provision of emergency services, as well as improving the 5150 screening system. All right, so this is where I am now going to turn this over to Scott.
Okay, was there any questions on what we've previously discussed? Okay, so what we're going to do right now is, I think Aditi, what she essentially did is kind of set the table of where we took the plan, both in describing how we received stakeholder and community input into what our needs and strengths and challenges were, and took all that and put together our next 3-year plan. So next slide. So this is that same slide that you saw previously of our current, and this is what it's proposed that we want to go forward. There's not a lot of changes. We did highlight some changes that we did want to talk about that are there, and there's actually a couple more I want to mention as well. The crisis access continuum and the outreach engagement under CSS are both being modified in that they're going to be coordinating more together. One of the requests that we heard was to have more outreach, particularly crisis outreach type of services. And so these two programs are proposed to be modified to be able to do that. That the crisis access continuum will broaden. That continuum will include outreach, more crisis services, which would be really a lot of what our outreach and engagement currently team does. And they've already been kind of doing that work as they encounter people in crisis. They try to work with them. If it's beyond their capacities, then they do get the behavioral health crisis team involved for if they need a hospitalization or further intervention such as that. And so the idea is that this is going to be more formalized. We're in the process of looking at how to do that. The state is strongly encouraging that we have a program like this as well. And when I mean encourage, I mean requiring it. And so we're going to be, being a limited resource county that we are, we're going to be really working to build a real strong outreach, a stronger outreach and engagement that includes mobile crisis. The full service partnerships will remain the same pretty much as they are. A new program there, which we're excited about, is the Native American Peer Counseling. And what that program is it's somewhat similar to maybe senior peer counseling, but it's designed for the tribal population. One of the feedbacks that we heard was that there was a real need to be able to have Native Americans working with Native Americans, of support and mentoring, and being able to pass on that wisdom and provide that support. And this is, the nice thing about this is we're looking at an entity that is made up of Native Americans, to be able to do this. And so but the idea is we'll be doing an RFP process to try and locate an entity to do this. Let's see, it kind of threw me off. We changed slides right here. So we also have there the trauma-informed co-occurring disorder. Although, the feedback that we received was, this is an important thing. Unfortunately, over the last number of years, this program has not really grown too much. In fact, it's kind of remained overfunded. And so we're actually using some of the funding from this program, not eliminating it, but we're reducing this program to be able to fund some of these other things that we recognize as greater needs at the moment. Can we go back to the other slide real quick? Okay, thanks. A couple of things I just wanted to mention on here also were mental health first aid under prevention and early intervention. We're looking at expanding that to law enforcement, which has also been an express need that our law enforcement, our community law enforcement, both the cities, the sheriffs, and highway patrol have stated they would like additional training in mental health as they being the frontline staff often encounter issues with this with our community. And so we're working at providing that that training. We've already have a probation officer that's been trained in this as well, and so they will be co-facilitating with our providers to really try and train all of our law enforcement in this. Something else, we have the innovation project. I want to mention that real quick. The multi-county full service partnership innovation collaborative. That project was designed and has really served to bolster our full service partnership program and really kind of defining what eligibility means, what graduation from the program means. And so it's now moving into more of a data gathering phase, to see how the interventions that we're doing are going to affect our program. And so because we're kind of in that program and that part of the program, it's kind of winding down. We're also looking at additional innovation programs. And that ties into the workforce education and training. The same folks who did the multi-county FSP collaborative are also now proposing a workforce education and training multi-county collaborative, which we're looking into. And so it could be something that could really help with our workforce education and training, particularly helping us recruit and retain workforces. That was mentioned in our needs, is we need to be able to do better at that. So we're looking at an innovation project to kind of help us along with that. So that'd be significant. This has been proposed since we put this plan together. And so if this develops as it seems to be, what we'll have to do is we'll have to do an amendment to this particular plan for that, which would require another 30-day posting for public feedback on that. But we will, if that happens, we will notify the community of this amendment that would take place. CAP facilities and tech needs, that is also progressing forward. We're really trying to develop our South Shore clinic. We have architectural designs set. We have other funding to support MHSA funding in this. In fact, MHSA funding is going to essentially serve as a match for this other funding. And so we're really hoping to be able to improve our facility in that regard. Electric health record project. We are in the process of converting from one EHR to a brand new EHR, which we haven't done for 15 years. And so we're upgrading that to get that in a better spot. So that's the major things that we're looking at with this 3-year plan. The 3-year plan, if you haven't looked at it already, is online, and you can review it in more detail of what some of these changes and modifications are.
Scott, we had a question in the chat from Kim. So I'm just going to read it out loud. So Kim asks, can you please repeat which program has been overfunded and is being reduced, and which programs this funding is being reallocated to?
Yes, that is the trauma-focused co-occurring disorder screening. That is the one that's being modified and reduced, and funding is going toward the crisis access continuum, essentially. Okay. Any other questions?
Mm-hmm.
Okay.
Should I move us into the next slide, Scott?
Yes.
Okay.
Maybe in the next one.
Okay.
I covered this one already.
Yeah. Okay. Great.
Okay, and so this is a very general overview of our budget requests of what we're going to look at for our budget. Next slide. Again, as Aditi explained, this is our breakdown of our funding. This is by law, is that community support and services is 76%. So you can see that's the major portion of our funding. As you can see on the side on the right there, half of that goes toward the FSP program, also by regulation. And then the rest of it stands for outreach and engagement and general service delivery, which is the other 50%. And that includes things like our peer support centers, our forensic program, well, you saw the list on the other previous page. I need to go over that again. PEI represents 19% and innovation 5%. That doesn't look quite like 5%. Looks a little more like maybe 10%. I don't know, but it's supposed to be 5%. The workforce education and training and capital facilities and tech needs. That actually comes from, we didn't explain that earlier, but that actually comes from CSS. You are allowed by regulation to take 20% of CSS and use it for either and or whatever, one or the other or both of wet or cap facilities and tech needs. So that's where we have to, where the funding goes. That's by regulation. Next slide. And so here's with the 3-year plan. This is, like I said, the very general overview of where the funding within those programs is being allocated to for each year of the next 3 years. Although as this is a 3-year plan, all 3 years are described, but the idea is years 2 and 3 are updated annually based on the current community needs. And so 2 and 3 could be different than what we're looking at now. That also depends on what our revenue is from MHSA, being that it's funded by 1% of over $1 million. That can fluctuate greatly over time, depending on what the economy is doing and so forth. And so we have to kind of adjust with that. For example, this current year, the projection is that we'll have a higher amount of MHSA coming in because we got a lower amount last year due to the extension in taxes. When you can file taxes for California. So we're supposed to get more this year than we did last year. And then in years 2 and 3, it should drop down to normal ranges. So we had to kind of balance that over a 3-year span. the two columns for each year represent total expenditure and MHSA expenditure. And the difference between that is the one on the right, the MHSA expenditure, that is actual MHSA funds that come from that 1% of over $1 million. That's MHSA funds that the state gives to us based on our allocation, which is based on our population. And the total expenditure is that with MHSA, we are allowed to use it as a match for Medi-Cal. And so we can gain revenue, which goes into MHSA within the program. You know, that's limited to those programs which generate Medi-Cal, can be used for that. So any services that are Medi-Cal based will also provide a Medi-Cal expenditure too. So the two of those together between MHSA expenditures and Medi-Cal represent the total expenditure for each column. Any questions about that? Kim, you have a question? And so is Michael. Good morning, Scott. Our team has trained law enforcement in mental health first aid and QPR, approximately 50 offices for the past 2 years. Community really want to hear this, just an FYI. Okay, yes, we do. Kim, you asked, I would like to know the county process for considering a cost of living increases between now and 2026, particularly keeping in mind the increase of operating and personnel costs when considering budget proposals from contracted providers. It's difficult to understand how contracted providers are expected to maintain and expand their services with minimal funding.
And minimal funding, sorry, wasn't like the appropriate word, but just keep, when I say minimal funding, I mean understanding where we're at currently and knowing where the economy is going and where it's been these last couple years. So just keeping that in mind. I didn't mean to specifically say that minimal funding in general.
Well, but there's some truth to it. I mean, it's maybe not minimal, but it's limited. You know, how much funding do we receive?
That was the word, limited.
Yeah.
Thank you.
Right. And so, you know, we did try to give increases in you know, for funding as much as that we could. On our non-MHSA side, we have a greater ability to do that because our Medi-Cal rates are increasing significantly. But on the MHSA side, we don't have that increase like that. You know, it's remaining fairly stable. It fluctuates again depending on the economy, and so it's, you know, it's a lot of times it's kind of hard to predict, especially over a 3-year period. You know, how the funding will be, which is why we have to update it annually. You know, if there is room to expand, then we try and do that for sure. But also we have to prepare for if it constricts, like it can, and has in the past. So we try and keep it fairly steady as a result, with knowing that, you know, we can expand when we can. I don't know if that answers your question or not, or if you need anything more specific.
So, like, we're in the process of submitting budget proposals, as you know, and we understand that there's been a slight increase, you know, but that is static. So, like, it's across the board for the next 3 years, and that's particularly frightening to see where, you know, as we look back on fiscal costs of program operations, personnel, benefits, things of that nature,
Those have increased in these last couple of years. And then to as, you know, an agency, as we're trying to consider, okay, what are we going to need in the next 3 years so that we can just sustain as a nonprofit, you know, that's frightening. It's concerning that
Kind of breaking up there, Kim, I think a little bit.
darn it. I'm just worried about the next 3 years. If there's not room in the budget to be able to account for that, what does that mean for these contracted nonprofit agencies? That's my concern.
Okay. Well, you know, like I said, it's just based on, you know, the funding that we have. And we definitely are, like I said, we do put out as much as we can, recognizing that also we have to be prepared if it does drop, you know, year to year, because it's extremely volatile as far as the level of funding. But that's why we do update it every year, as contractors, when that comes up, we'll be able to amend you know, contracts to account for that. So and that could, you know, now I'm thinking about, that might be a little bit of source of your concern. One thing that we're doing this year that we haven't done previously is we're doing 3-year contracts with our providers that match the length of the plan, as opposed to year-to-year contracts. And so which is, you know, hopefully will help with everyone's convenience to be able to have a 3-year, then as opposed to doing them, updating them every year, or doing new ones every year. So with, you know, as things change, though, we can amend each year, you know, depending on what the needs are and what the ability is. So even though we're looking at a 3-year contract, that's not, sounds weird to say, it's not set in stone, because it is, but it also is, you can update it as well.
Thank you.
Okay. Any other questions? Okay, next. Okay, this is more information purposes, but we do have our annual revenue and expense reports that we do year to year. The most recent one, which is the most complete one, is 2021 through 2022, and that's also on our webpage, where expenses have, you know, have gone. And then we also have all of our previous ones archived, also accessible, that can be reviewed. We'll be doing 22, 23. It has to be in by the end of January, and so we'll be working on that. But it's, you know, we talk a lot about the budget. This is where actually the expenditures were, you know, in relation to that budget. Next slide. Okay, you know, I just want to also just mention.
This is Carrie over at the Circle, and we actually have a question here.
Okay.
So.
Okay.
Okay, good morning. I'd like to back up here. You was mentioning about the counseling. Now I'm gonna just give you some info. So we needed a counselor pertaining to suicide. And when I called here, they didn't have a number, but they were going to check it out. And this person wanted to talk with somebody. So we got hold of the person that's hired in the suicide, you know, that position. And he did call me back, but it took a while, but he told me he was taking the children on a trip. And I thought, what's he doing? Thought it was for suicide here. to talk with somebody, they wanted to talk with somebody. Well, this person, and, he said, I don't know anyone here, but I have to go take the children on the trip, so just have them call 911. So I didn't like that answer, and I didn't know where else to go, and she didn't want to talk to no 911 person. You know, that person needed help, so I just want to run that by you and let you know what happened, and he is also paid by this, mental health.
Okay, well, that's a second.
Yeah, also, so I'm from Robinson Rancheria, we don't have a social service program up there, and, you know, we always refer to tribal health all the time, and some get help out of there, so I push them to call the circle here. There is a lot of available services you have here. But with that, if they were to call, then I guess the staff would refer them out to wherever the service is.
We can talk about that.
Yeah,
Yeah,
okay.
yeah,
Yeah,
the meeting's over, I can explain how that works.
yeah, because I was asked some questions here and I said, I don't really know. I said, they have a staff, you have to call here and I have to find out. But transportation was one thing that was needed up there. I was elders coordinator for some time up there and I retired, and so I still help the elders, but they always need rides and we don't have that for Robinson. You know, it's really hard to go to the doctor or do shopping. Can they provide that service here? I don't know. So those are my concerns. I just want to run that by you.
Okay, we can talk offline to kind of troubleshoot some of those things right there.
Yeah.
You know, because there is transportation that's available for folks that have Medi-Cal, for example, to medical appointments. So and there's some things that can help out.
Yeah.
One thing I did want to mention real quick or describe real quick. Maybe you can go back, Aditi, to the slide that had the breakdown of the percentages. There you go. You know, the pie chart. And I just put this up here for a moment to discuss some pending or possible pending legislation that I just want to make our community aware of if you're not aware of it already. The governor has proposed changes to MHSA, some what is being referred to as modernization of MHSA. As you saw from Aditi's presentation, you know, MHSA has been around since 2004. And so there's felt the need that there is modernization, which I take it as euphemism for change. You know, they want to, there's proposed changes for it. Because it was voter approved, MHSA, it has to be voter changed. And so the governor is proposing that these changes be put on the ballot next year. Either next spring or next fall, probably next fall, because that's going to be the larger turnout. And it's currently going through the legislature right now. It's expected to be pushed through the legislature very quickly to get it, well, just to get it done quickly, I think is the idea. And then it will be to be put on the ballot for next year. It's actually pretty drastic changes to MHSA that they're talking about. This current pie chart, they essentially want to toss it out the window and reallocate all the funding. Reallocation would be instead of broken down 76, 19, and 5, would still be broken down into thirds, but they're looking at a third going still to FSP. And so that part really wouldn't change too much. 50% of 76% is close to a third of MHSA. So that wouldn't change a whole lot. And then the big proposal is they want to propose taking a third and using it for housing, which would be a new service, providing housing to folks with behavioral health issues. And they're also, then what they're saying is then the last third would be everything else. That's what you're saying, including PEI, probably innovation would be eliminated, but it would be, everything else would be condensed down to a third. And so they haven't said exactly what housing means, per se, although, I mean, I think we've got a general idea what housing means, but actually what it includes. And so I think that'll make a big difference of, how they work out what housing will include. For example, will include preventive services. We're not sure. They're still working on that. But it could be, some very, very significant changes if this is approved. I don't think this will affect this current 3-year plan. Because if it goes to legislature next fall, that'll be, in year 2 of this. And then it'll probably take, a year of transition. At least even the planning of the transition will probably take the following year. So I feel pretty confident this 3-year plan will be set for this next 3 years. After that, I'm not sure. It will depend on what the outcome of this, I guess, next election will bring. But it could be some real changes that are coming in, and I just I bring it up because I think it's important that our community be following this, because this will affect a lot of the things that we're doing, and so please and as we're doing next year's planning for the update, I will continue to update the community of what's where things are currently, and how it might impact us, our county. So this be aware. Okay. Any questions about that? I'm not sure if I explained that well or not, or just rambled on too much. Okay. Well, let's advance forward. And we're at that time now for public feedback and comment, why we're actually all here.
Scott, real quick, this is Carrie over at the Circle again, and Les had to leave from the Pathfinders group, but he wanted to express his gratitude from himself and the whole Pathfinders group for listening to the needs of the community and providing some support for change.
Well, it's an honor. So thank you. Aditi?
Thank you. Yeah, I just wanted to say, this is, I just want to reiterate that this is where we're opening the discussion up. So would love to hear from folks, especially as, we walked over the different pieces of the MHSA 3-year plan process for FY 23 to 26. So this is really us inviting any inputs, feedback. I want to reiterate, feel free to use the chat. You can use the raise hand function. And you can, once we kind of have that lined up, you can put yourselves off mute, and we'd love to hear from you. So this is just a invitation for folks to add their public comment. Thank you.
You have a hand up there.
Yeah, I have it.
Go ahead.
Go ahead, Christina.
Good morning. Really great to see everybody. We've been on this journey for several months, and what great work. I really appreciate it. As you all know, I'm Dr. Christina Laces, the Chief Medical here at Sutter Lakeside. If you hear some background noise, it's because we have a helicopter landing, and we are the critical access hospital. And the helicopter is a reminder. My question is, I also serve on the statewide behavioral health task force, not as a voting member, but a participant. And what I heard recently was that there is a ballot proposal to increase funding for residential care, group home care, especially around mental health, people that experience mental health challenges or co-occurring disorders. Is anybody aware of something that's coming up on the ballot? Maybe a bond regarding funding of these services, because we certainly need more of residential care.
I have not heard that specifically. I have seen some proposals and possible grant funding for that. I would not be surprised that's in the works. It wouldn't be MHSA funded, but it would be the state trying to address that. That's been an issue that's been existing for a long period of time. Counties currently have to use realignment funds to support that, and those are limited as a result. The other issue that ties into that is there's just a dearth of actually available beds for these type of things. Or we have staff that are just constantly trying to locate beds and placements for folks. It's an ongoing battle of begging, borrowing, and not stealing, but as much as you can to try and get placement. So I think one of the things that they're looking at is trying to develop the infrastructure to be able to support that. I've seen some grant funding that's been proposed for that. So maybe that might be something similar that you had heard about.
Yes, I'll try to research further, Scott, so that all of us can have the awareness of if anything is coming up on the ballot and anything that we can be advocates for, that we have the opportunity to advocate for Lake County.
Great, thank you.
Mhm.
And then the harbor, I think Janet at the
Yeah.
harbor.
That's right. Go ahead, Janet.
Yeah, okay, I guess you can hear me. My concern is, I am running across a lot of elders who are in the homeless population. And some of them are in very bad shape. They're not eating properly. When you try to give them food on the street, I live right next to Grocery Outlet, and I encountered 4 yesterday. Some of them are in such very bad shape that they won't take any food from you, and they don't make sense whatsoever. They can't complete one sentence. So I'm very concerned. I'm with senior peers, and that type of population we don't really deal with, but we are coming across some of this because they end up in the nursing home for a while. They fell, and so they end up over there. And the problem is that they're showing clear memory loss, like somebody has to adequately assess them for dementia. And then these people think they should, that we senior peers should try to find housing for them. The housing situation for people like that is dire. There's just really nothing, and they have so little money. And so they're sitting in the nursing home where they should be, some of them. They have no family, and you're trying to make sense to them that you need to stay in the nursing home. You have a real problem in this county of elders about to go homeless or are in your huge homeless population here. So all I can say is maybe give senior peers some more money so we can maybe find some more volunteers. And you guys have got a real problem you need to face. We are an older population ourselves as a volunteer with the service. And, you know, some of us have to retire. You know, you have to think we're an older population, and that means you have to constantly find new people to train them, and other people in our service having to take care of a loved one at home is probably dying or whatever. And so you have an attrition problem with your worker source. Thank you.
And I appreciate that comment. Yeah, it is recognized that there's an ongoing issue with that. I was just talking with our emergency shelter in Lakeport, and they were concerned, as many of you are aware, that the emergency shelter is essentially it's an overnight shelter for folks, you know, where they come in around 3 o'clock and then they leave around 8 to 9 the next morning. And one of the things that they were concerned about is there was a number of older homeless folks who were, you know, just kind of like sitting on the lawn waiting for the place to reopen again. And so, you know, they were letting folks in, you know, early just to get them out of the heat. But one of the things that they, like I said, that they noticed is that a good portion of them were older adults. So this is, you know, definitely a bigger problem in our county that we're gonna have to face, and it's gonna take a community wide effort to do that. We're definitely, you know, trying to work in that direction. MHSA does fund not only the peer support, senior peer support, and through Konocti senior support, and the friendly visitor program. It also, you know, funds an older adult program for mental health, and also funds an outreach staff person who's really doing great. He's making a lot of connections, which is I'm really happy to hear about, because that's exactly what's needed. We have a lot of folks that are addressing older adult needs, but having, you know, a coordinated effort, I think, is one thing that we really need to have to do it. Other comments?
All right, we have a comment here.
Okay.
This is Bernadine again. Yeah, the elders, I understand where the lady's coming from. We have the same situation up there. Maybe this could be written into a plan one of these years for mental health to have a large, large place that would take the elders in. We have an elder up there. She's barely walks. She pushes herself out on the street and sits in the wheelchair, and she's always hungry. You give her water, somebody will stop and give her food. She won't go to the doctor for checkups. I've taken her, and she had a lot of health issues, and she refused for the nurse to touch her and all that. And she's hollering. And so anyway, I worked with that and was able to do some things for her, but I did it in a way, just I convinced her. I talked really nice to her because she's a very big lady and she likes to swear and cuss people out. But anyway, her home it is in a bad situation. She needs to be put into a home. She doesn't eat regular meals. She has a lot of money, and it just goes in the bank and sits there. And sometimes I used to take her to the bank, and she'd get her money out, and then whatever she do with it, I don't know. give it to family maybe, but her family there again, her family doesn't even care for her. Or she's too mean. They don't have nothing to do with her. And if she was talked to by somebody, I think she would go into a home or a caring home where she'd be taken care of. She talks good. She remembers when I talk about things, she'll pick up on it. She's sometimes she can be a nice lady, but then we have other elders out there. We don't have money from Robinson to service our program for elders. We ended up having a thrift store. We raised money when I was there, and I went to the casino. Money when they sell the jewelry that was given to us. We did have an income. With that income, we provided whatever services. Took them out to activities, went to the ocean, went to powwows and fun things. Paid for other services, little things, but now we're out of money and the place is closed, and I still have meetings there with them, and we talk about the tribal issues there. It's all volunteer. And so I know the elders up there need a lot of help. They have garbage that like to be hauled away, but you gotta pay for it. They don't have the money. They don't have a truck. I used to have a truck. And I used to go haul things away for them, but now I don't have that truck. And we wait for the tribe to do things, but they're doing whatever. But the service out there on our ranchery is a great need for the elders. And I'm just putting that by you. We can use this department a little. Okay, that's it.
Okay, thank you. It's I definitely hear you. You know, the older adults, the elderly in our population, they have gone through their entire lives of you know, gaining experience and wisdom, and they deserve better than a lot of times what they end up in the place they're at. And I think we all kind of feel that, and honoring our elders is I think a big part of what we need to do as a community as well, to be able to address and help where there's gaps like have been described. It's not an easy thing. There is, you know, a number of different I think ways to approach it. With the, you know, we have the adult, was it the community on aging, and you know, some other things where providers can work together to try and address some of these things. But this is not going to be something easy to do, for sure. Any other comments? Right. Well, if you do have anything else that you don't want to bring up maybe right away, or just want to contact me separately, please do. I had my email up before, and then I think we'll show up again on a later slide here. But you can email me, you can give me a call at Behavioral Health here. Any way that you want to communicate any other feedback that you either want to say for that or you think of later, please do that.
Thanks, Scott. I do want to give it a minute or so in case anybody has any additional comments they'd like to raise here. We're also happy to go back to any specific part of the slide if you'd like us to discuss anything specific.
This is
Oh.
Bonnie,
Okay,
and I was wondering what we're doing for the post-incarcerated.
okay. We do have our forensic program, which is funded through MHSA. We also have some additional funding that we receive for that to assist with that, which is mental health block funds, which we receive, and which are designed to help people that are coming out of incarceration and to help back into the community. And so that program exists. We're also in the future, well, presently in the future, we're working with jail medical to try and better and increase our services within the jail for those that are incarcerated. One of the things we're really concerned about is those that are ruled incompetent to stand trial. This isn't an MHSA program per se, but it is something that we're concerned about, and being able to make sure that folks, our charge as a community behavioral health is for the misdemeanors, and but even the felonies, it's proven across the state to be very difficult to try and address this population, and the difficulty lies in there's not a lot of placement options for incompetent to stand trial. And the idea is that people go receive treatment for incompetent to stand trial, and their competency is regained, and so they can continue with whatever charges are against them. And so that's because there's a real gap in that statewide. We're looking at trying to develop alternative means if there isn't placements available. One thing that we're really trying to look at is doing restoration competency while someone is in jail, which again needs the cooperation of our jail medical to do that. And so, this population is something that we definitely pay attention to and address. We also address it very significantly in our substance use disorder programs as well, and which is also a good thing. Raven?
So I work in the diversion program with the mental health side. I'm kind of new in this position. One of the concerns for me is because I've worked in the substance use and I'm working in mental health, so I kind of got background of the substance abuse. I worked in the substance field for 6 years. And so coming over here to the mental health side, it's new. Being I got my master's and I'm trying to learn how to do that process. One barrier or gap in service that I seen was a client. He was in jail, he was incarcerated, he's an IV user. We knew that if he got released on the streets that he was going to go back to using IVs. So we were trying to get him an assessment with the SEDS department, and I'm a co-occurring specialist. And the time frame it took to get him to get some type of assessment was way too long. And not just that, but he ended up getting let out on the streets and he used again. I kind of spoke out about like, hey, there's another process. Like, I'm aware of different processes. That client could have easily went from jail straight into a treatment center without having to wait for this long assessment process to be placed on a waiting list. When he's an IV user, he should have been placed at the top. Some people didn't know that, and he almost got shuffled through. And I had to advocate for that. And it was a little frustrating because it happened again with another client as well that was sitting in jail, detoxed, ready to go into treatment with free treatment. Even if the client didn't want that, they would at least have that option to go from jail straight into treatment. But the barrier was that the time frame of the assessment process and the backup on the assessment, when I easily could have, with the skills that I have, the license that I have, I could have easily helped that client. But because they needed to go through a different department, my hands were tied. So that's something that I do want to say. I did bring it to my supervisor and her supervisor, but I think it does need to be addressed. Thanks.
Thank you, Raven, for expressing that. That is that's a really good example of where improvement is definitely needed. We're hoping, you know, one of the things that's kind of happening, this is again beyond MHSA, is there's more and more integration between mental health and substance use disorder services. And, you know, this is designed by the state, so it's not just us doing this. And it's been going on for the last 10 years, but it's you know, even more and more intensified, particularly with Medi-Cal reform, with Cal-AIM, and also the organized delivery system that SUDS, substance use disorders, is going through to kind of change them, which our county is adopting within the year. And so, you know, I think together with that, one of the main ideas is to have a more unified intake process, as opposed to, okay, you got your, you know, your mental health assessment, now you have to wait around for your SUDS assessment, you know, and you know, trying to rectify so it's, you know, kind of one entry. And then of course, you know, along with that, as I mentioned, you know, is more integration with jail medical, so that, you know, folks like this can be identified, and we can, you know, hopefully work to do like what you're talking about, to get placement, or at least get them into services as soon as they get out, you know, depending on what the assessment is, you know, but to get them assessed before you know, they even get out. So these are things that I know as the department that we're working on.
If I may, Scott, I would like to piggyback on that from the medical side. And Raven, thank you for bringing that to our attention. I was also working at Mendocino Community Health and expert in addiction medicine. In that work, in Mendocino County, we had a regular standing meeting with our jail coordinators and medical staff in jail, and we were able to do case management and handoffs with that meeting. And so, Raven, I can connect you to the people in Mendocino Community Health that help to be that bridge to medical. I understand that this individual was detoxed, but still could potentially be needing medication assisted treatment. Remember, it's not just about buprenorphine. We have other medications that help to support sobriety, including your SSRIs, including gabapentin, including naltrexone. And so just as an advocate in the medical field for addiction medicine, Raven, just reach out to me. I'll put my email address in the chat for you, and I can connect you to my partners at Mendocino Community Health that have a clinic here in Lakeport.
Thank you.
Great.
Well-
Yeah, I was gonna say any other public comments?
Well, let's go to the next slide.
Okay, sounds good. Thanks, Scott. Thank you all
So-
for, oh, did you
I was
want me?
gonna say- Yeah, I was gonna say a couple things here real quick
Yeah.
before we
Go ahead.
jump into the next steps. I just wanted to express my gratitude for our previous steps that we've done. This has been, no, you can go back to the next slide. That's
Okay.
fine. But you know, this kind of introduction to this slide, and that's, you know, this has been, as Dee Dee's kind of mentioned, is, you know, a 6-month process, and you know, to get to this point, it's kind of the culmination of this 6 months process. You know, where we've gathered information from the community, we've you know, put that together into a plan, and then this is the, you know, presentation of that, and you know, the 30-day notice for people to read that plan and you know, decide what they think of it. And so this is that, you know, the culmination of that, as far as with our community goes. And you know, with that, I just want to express my sincere gratitude for your participation. You know, a lot of you have been here since January working with that, and so you know, it's really appreciated. You sticking with us and providing us, you know, I think some really good information. And so, you know, get anything else out of this, please understand that very grateful for the time that you're putting into this. Thank you.
Thanks, Scott. So on that note, I wanted to give everyone an overview of what follows this public hearing, so you can kind of see what's up here on the screen. So again, I want to completely echo what Scott just said. We're very grateful for everyone's participation thus far, and folks who especially chimed in during the public comment phase of this. What we will be doing is right after this meeting, we'll be finalizing the 3-year report, and we'll incorporate the public comments that were raised today and those that we received when it was up for public comments for about a month. And then after we do that, we will be presenting the 3-year report to the Board of Supervisors for their final approval. That date is being finalized as we speak. And then finally, the plan will be submitted to the Mental Health Services Oversight and Accountability Commission, the MHSOAC. So that's kind of going to be the final step in this process. One thing that we would really appreciate and would like to kindly request everyone is to give us feedback about this meeting. We really would like to invite folks to take our brief survey to share any feedback about this meeting and any additional comments that you'd like to raise about just this MHSA 3-year plan process. For in-person attendees, we do have paper feedback forms that have been made available. We also have the link my colleague just dropped in the chat and the QR code that you can use to scan. And you can have access to the feedback survey. So thank you again. We really take a lot of the feedback survey, and our hope is to just improve and make this a more sort of accessible process for everybody. Thank you. Awesome. Yeah, quick plug for those who also, while we're on this slide, is for those who haven't had a chance to complete our demographics form. This is again just a gentle reminder to complete that. We do like to capture all this demographic information at each of our public meetings. So thank you again. And then that brings me to our very last slide, which is a heartfelt thank you for those who were able to make the meeting today. You will be able to access this recording and the slides on the website link right here. And if you have any additional comments, as Scott mentioned, we have our contact information up here. Feel free to send us an email. And we'd love to continue to hear from you.
Also, just want to put in a couple of plugs for 2 other community meetings that are the next 2 Thursdays at this time. The one next week is on the Pathways Hub program, which started off as an innovations, MHSA innovations program. And so, that's the project of linking agencies together, closed loop referrals, coordinated care. And that's a really exciting program which is going. And so next week at this time, there will be a report on that and, to the community. And, also, again, looking for public feedback. Then the week following that, on the 29th at this time, it will be the department's relaunch of the Cultural Awareness Committee, which will be to help, kind of guide the department to do better at our cultural competency, cultural awareness, and be able to strengthen that, making sure that really is ingrained with all that we do. And so, if you are interested in that, please go to our website to find out more information to come. So again, two more community meetings that I hope to see folks at.
Thanks, Scott. All right. So this is where I think we can officially end the public hearing today. Thank you again for your participation. Feel free to reach out if you have any additional thoughts or questions. And have a great rest of your day. Thank you so much. Bye.
Thank you.
Thank you, everybody.